Welcome to the 2022 Head and Neck Cancer Survivorship Symposium hosted by the Head and Neck Cancer Alliance and the American Head and Neck Society. Our session is the financial burden of head and neck cancer. I'm Dr. Michelle Chen, Assistant Professor at Cedars-Sinai Medical Center, and I want to thank our medical panelists, Dr. Krupal Patel and Dr. Leila Mady, as well as our head and neck cancer survivors, Charmaine White and Kenneth Hansen, for presenting on this important session topic today. To begin, I would like to provide some brief introductions. So Charmaine White is a former home health nurse. In 2020, she was diagnosed with tongue cancer and underwent a subtotal glossectomy. She has limited resources and has been supported financially by a close friend throughout her cancer journey. Diagnosed in 1995, Kenneth Hansen was diagnosed with oral cavity cancer and experienced several recurrences. He has undergone multiple surgeries and reconstructions. He owned his own plumbing business and has excellent health coverage. Kenneth estimates that the cost for his care has exceeded more than $1 million. Next, we have two medical panelists. Our first is Dr. Krupal Patel. He's an assistant member at Moffitt Cancer Center and assistant professor in the Department of Otolaryngology, Head and Neck Surgery at the University of South Florida. He has subspecialty training in head and neck oncology, as well as microvascular reconstruction. His research interests include cancer care delivery, financial toxicity, and insurance literacy, as well as real-time patient monitoring to design just-in-time interventions to improve patient outcomes. Our next medical panelist is Dr. Leila Mady. She is an assistant professor in the Department of Otolaryngology, Head and Neck Surgery at Thomas Jefferson University, and she has subspecialty training in head and neck oncology and microvascular reconstruction. Her current research focuses on healthcare services and population health to improve the delivery of cancer care and oncologic outcomes, including financial toxicity, frailty, and survivorship. So I'd like to turn it over to our first survivor, Charmaine White.
Okay, when I found out I have tongue cancer on September 9, 2020, I was eating and I bit my tongue. And by biting my tongue, it hurt. So I went to the dentist to find out what was wrong. And when I went, they saw something and they sent me to a specialist. When I went to the specialist to do a biopsy, and then they called me in and told me that I have surface tongue cancer. They referred me to Moffitt. And I went to Moffitt, they do some tests. They told me they have to do some tests and stuff. So from there, I've been paying money because I didn't have health insurance. And so I have to pay out my pocket for every test that done. And so when Moffitt told me that I definitely have tongue cancer, they have to do surgery. Up until then, I was working. All my life I work. I don't know nothing else but work. And so what happened, after for surgery, I still was paying him for treatment, medication, or that's where my financial burden comes in because I run out of money, you know. And so from there, it was hard shit for me, you know, it was difficult for me to find the money for medication. Most of the time I have to use my credit card to get pay for my medication and all the treatment that they give me. So what happened after that, surgery, I come home, you know, I didn't have the financial to get all my medicine then, continue to get my medicine because I ran out of money. So Moffitt, they give me some assistance and stuff like that. And it was very hard. It was very hard on me, you know, because I didn't have any more money left. And each time they have to go, they have to pay, and I didn't have it. So it was a difficult time and stress on me. I never really talk about it. I would tell everybody I'm fine, but truly I wasn't fine, the health was difficult. That's a part of the rest of my story.
Thank you, Charmaine, and God bless you. And I hope that your health is good. I've been very blessed. I started in 1995. My dentist noticed the spot on my tongue, and it turned out to be squamous cell cancer. He sent me to an oral surgeon who took a sample of it, and it was, and they found out it was cancer. Then they told me that you have cancer, and I said, well, what's the next step? They didn't have much of an answer, so I said, oops, I'm in the wrong place. So I talked to a number of doctors, and I found a very highly recommended ENT, and he looked at the surgery, the sample that the oral surgeon had done, and he said, the margins are clear but close. So he did another surgery. And I went after that, they watched me, I had a scan, and after that, a couple of years later, cancer turned out. And at this time, we'd moved down to Florida, and I had a good ENT doctor. And I would say over the period of 10, 12 years, he did about every 2 years, he did surgery on my tongue, basically the same spot, same area. And as time went on, I built for 18 months, 2 years, and it would reoccur. One day I woke up, and the cancer was always on my right side, and I woke up in the morning, I noticed a lump on my neck on the left side. So I went to see my regular doctor, my primary care doctor, and he knew my situation. And so he called the ENT and said, I'm sending 10 over. I want to take a look at this. So I went over to look. I had a scan, I had a biopsy. And at that point, that was the first really major surgery I had, because they did a radical net dissection where they took out the tumor, they took out lymph nodes, they took out salivary glands. Then they sent me to a radiologist, and so I had a course of radiation. I had 30 days, and then for a couple of years, I saw the ENT, and I also saw the radiologist on a regular basis. And after a couple of years, the cancer turned out. One day he said, come with me. And he took me to the hospital and up to the head and neck clinic and said, is Dr. Eldiri here? I want to see him right now. And so they took me in to see Dr. Eldiri. And the interesting thing is Dr. Eldiri had worked at Moffitt and was now at Emory. So Dr. Eldiri saw me, we did a scan, the cancer was that. And the surgeon, Dr. Eldiri, I had my tongue replaced for the first time. At this point, they did a fat graft from my wrist. And the surgeon that did the actual installing of my new tongue is Dr. Wadsworth, who is now at Moffitt. So as time went on, we were in Georgia for 3 years. I had several surgeries, and plus my tongue was replaced with a flap. And at that point, the poor weather for me with all the surgeries I had, and Georgia's not cold, but it gets down to 30 degrees, I suffer. So the best place for me to be is in a hot, humid climate. The hotter the better, it's the better I feel. So my wife then was concerned about me losing my doctors, and Dr. Eldiri said, that's absolutely no problem. I've been at Moffitt, I'm going to send it down there to Dr. Patel, and he's fantastic, he'll take care of that. So I moved, and I started seeing Dr. Patel and had scans, and the cancer reoccurred, and Dr. Patel did a couple of minor surgeries trying to take it out through my mouth, and it was not possible. It was now in my jaw as well as my tongue. And so that's where I met Dr. Patel. And Dr. Patel, I will say, is the most amazing surgeon I have ever known. And what he did for me and what Dr. Patel did for me is they gave me a good life. They gave me the life that I have today, and without them, who knows where I would be and what would have happened. My medical expenses are well past $1 million. I've had numerous surgeries, several major surgeries. When Dr. Patel replaced part of my jaw, my tongue, that was a 20-hour surgery. And so the cost of all these things is amazing. I have a regular scan every 4 months. I've had, the second time I had radiation after the surgery with Dr. Patel, and I also had chemo. And all that, the cost adds up unbelievable. We've had good insurance, but there's deductibles. There's time that I stopped working when I would have continued to work. The transportation expenses going back and forth, the times I've been in the hospital when my wife has come and stayed in the hotel. So expenses add up. I feel terrible for Charmaine, but it sounds like she's getting some financial help, and that's fantastic. But for most people, the cost of what the cost can run up to when they've had the kind of surgeries and that I've had, it's beyond belief. And if people don't have insurance, I just don't know what the answer is to help them. But it's extremely expensive for all these things to happen.
Hi everybody, thank you for joining. My name is Krupal Patel. I'm an assistant member in the Head and Neck Endocrine Oncology Department at Moffitt Cancer Center. Thank you again to both Charmaine and Kenneth for sharing their experiences and with the financial burden and cost of care. For this session, I will briefly go over the financial toxicity and what that means, and then I'll hand it over to Dr. Mady to go over specifically for some data on head and neck cancer. What financial toxicity really means and describes is the cost implications as part of cancer care, which includes both objective financial burden and subjective financial distress that patients and caregivers experience not only prior to starting treatment, during treatment, and as well as in the survivorship phase after a successful treatment. Next slide, please. Cancer-related financial hardship in the United States, we spend more on healthcare than other industrialized countries, as the graph below shows. In terms of healthcare spending, in the United States, it has grown much faster than the rest of the economy in the recent decades. And what that means is we are spending a significant amount of money for getting the same amount of care. Next slide, please. Overall, Americans are paying more for healthcare, as evidenced by the figure on the left, where we are paying higher price for the same drugs compared to other countries, which include England, Norway, and Ontario, Canada. Next slide, please. There's been recent news articles as well on cancer-related financial hardships that have really illustrated what this means for a cancer survivor. Next slide, please. Financial hardship is detrimental to patients and their families. Cancer-related financial hardship is increasingly common, which results in high launch price of new cancer therapies that increase over time, insurance benefit structures that lead to high patient out-of-pocket costs, and it also impacts the sick leave, employment changes, and job loss among patients and their caregivers. Next slide, please. This is a very complicated interaction that occurs after one is diagnosed with cancer. What ultimately leads is a financial stress, which has an objective burden, as we talked about, and a subjective burden. With the objective burden, it includes the out-of-pocket costs, loss of income, unemployment, and informal care. Under the subjective burden, it includes the perception of financial hardship. And what this ultimately results in is patient-centered outcomes that are significantly impacted with decreased quality of life, increased symptom burden, increased psychological distress, increased or decreased treatment adherence, and the increased mortality. It also impacts family-centered outcomes, meaning both the patients, caregivers, and extended family, where the family may have decreased quality of life, as well as increased psychological distress. And this has been underreported in multiple studies. What that means is, as a potential solutions, what that means for potential solutions is that we need to proactively involve patients and their caregivers in advanced care planning, palliative care, and symptom management, as well as providing support and information on services such as financial counselors, so that we can work towards the common goal of reducing financial stress. Next slide, please. A recent study funded by the Kaiser Foundation of close to 2,400 US adults, which included 1,700 cancer survivors, indicated that cancer survivors used up most of their savings. Close to 43% of patients withdrew money from college or retirement fund or their long-term savings. Close to 3/4 of the patients skipped or delayed their medical care due to costs. About 1/3 of the patients changed their living situation, such as had to move in with their friends or family. And 1/4 of the patients unfortunately had to declare bankruptcy or lost home to eviction or foreclosures. These are staggering statistics. Next slide, please. At Moffitt, I've had particular interest in assessing financial hardship in head and neck cancer survivors. And for this, we recently undertaken a study where we used the cost composite score, which includes a number of questions that assesses the financial hardship. The score ranges from 0 to 44. We enrolled 27 patients prior to starting their treatment prospectively, and the median cost score was 27. What we found is that close to 41% of patients reported high financial toxicity, which means a score of less than 22. We also assessed health insurance literacy in our head and neck cancer patients. This particular scale includes 4 measures: the confidence of choosing an insurance plan, comparing health plans, confidence using insurance, and being proactive with insurance. And the health insurance literacy ranges from 0 to 84 points. For this particular one, we had 48 patients, and our composite health insurance literacy score in our population was 42.1, which meant that 45% of our patients reported low health insurance literacy, meaning a score of less than or equal to 60. Next slide, please. In summary, insurance literacy measures may help in reducing financial hardship. Both of these studies have been done with my collaborators, Dr. Kia Turner and Mia Revlin. Now I'll hand it off to Dr. Mady, who will go over more specific data on financial toxicity in head and neck cancer patients.
Thank you, Dr. Patel and Dr. Chen and Charmaine and Ken, and really to the whole H&S and Head and Neck Cancer Alliance for giving us the chance for all of us to come together and talk today about these really important topics. So like Dr. Patel mentioned, I'm going to delve a little bit deeper into some of the own experiences we've had with our patients with financial toxicity, and touch upon how this potentially impacts the care that's given and clinical trials, and look at how can we tackle this problem. That's something that Ken brought up. What do we even do about this? So to start, we looked at financial toxicity in some of our patients. This was done at the University of Pittsburgh when I was a trainee there. And we looked at 104 survivors that had insurance, first of all, and had finished treatment at some point already for cancer of the oral cavity, the oropharynx, and the larynx or hypopharynx. And we surveyed patients on financial toxicity using that same survey that Dr. Patel mentioned, the cost score, and also another instrument called the Financial Distress Questionnaire, which is a pretty short 2-question survey. And looked at some other things like quality of life and how people cope and tackle this problem. And next slide, please. And here we have 3 graphs that show the financial toxicity scores on that vertical line. And the cost score, like Dr. Patel mentioned, lower scores mean worse toxicity. And we looked at 3 patient factors: education level, and then whether or not a patient had a spouse, and then the type of or area of the cancer, whether it was the oral cavity or pharynx and the larynx hypopharynx. And what we found is that patients with lower education levels, and those that were not married, and those that had larynx and hypopharynx tumors reported lower cost scores, meaning worse financial toxicity. And this was the first study that actually reported these differences by site, meaning whether your cancer is in the mouth or the throat. And so I think it's a really interesting potential hint at some of the factors that can be impacted maybe on a patient's ability to go back to work. For example, if you can no longer use your voice, can that impact the type of job you have? And sort of what Ken mentioned, can that impact your ability to go back to work? And so I think this is sort of starts to hint at some of the ways and strategies that we can tackle to deal with this problem. And so next slide. We also found that there are things that actually can protect you in a sense, and patients who were older and had higher earnings had less financial toxicity. So the older you are and the more you make, naturally, the less money you lose, the less financial toxicity you seem to have. And this is pretty consistent with what's been shown in other cancer types. Next slide. And so why do we even care, right? Why does this matter? Cancer patients are known to already have higher out-of-pocket expenses than other patients who have chronic diseases. And they're more likely, in fact, 2.5 times more likely to declare bankruptcy. And for people who do declare bankruptcy, there's an 80% higher risk of death. And so that is really tremendous. And why does this happen? What's the link between financial burden and higher mortality? And so this concept of financial toxicity fuels worse well-being, worse quality of life, and worse quality of care is how financial toxicity can basically lead to higher death rates. Next slide. And so what do patients do, to cope with all of these mounting expenses and the less income and less wealth overall that you have during your treatment? Patients and their families adopt lifestyle modifications. Click, please. These include cutting back on leisure activities, reducing their spending on clothing and food, working longer hours, and even cutting back on treatments, prescriptions, or even cutting back on medical care that they might need. Next slide. And so to deal with all these out-of-pocket expenses, even if you have insurance, we found that 62% of our patients use financial coping mechanisms, meaning dipping into your savings or your loans, a lot of what Charmaine talked about. And we found that, patients were less likely to use these coping strategies if they reported less financial toxicity, less subjective financial burden. Next slide. And so in this other study, we wanted to look at this relationship between subjective financial toxicity, what Dr. Patel talked about, this emotional subjective burden, and objective financial metrics, meaning costs and out-of-pocket expenses. And we looked at medical and pharmacy claims, meaning claims and expenses that were only related to your head and neck cancer diagnosis over a 5-year time period. And we looked at those expenses with the surveys that patients reported their subjective toxicity levels. And we found that the out-of-pocket expenses for each member over a whole year, first of all, varies, as you could tell by all these bars going up and down, tremendously by the type of insurance you have, right? And the benefit plan that you might have. And overall, patients spend an average of $700 out of pocket per year. And maybe this doesn't seem like a lot, click please, but consider, 40% of American families can't cover an unexpected cost of more than $400. So these numbers are real for patients. Next slide. And even 4 or 5 years out of treatment, as you can see from this graph arrow, this escalating arrow, is that patients, the bottom line is that patients are still spending out of pocket years and years after their treatment has ended. Next slide. And very similar to the number that Dr. Patel reported, we found that almost 45% of our patients also reported high financial toxicity. And even again with insurance, our survivors experience out-of-pocket expenses that last long after treatment has ended, and even 10 years after your treatment, there was an average of $700 for patients spending out of pocket. Next slide. And this is something, again, very similar to the themes that Dr. Patel mentioned. It doesn't just affect patients. We've seen that caregivers who take care of patients that are out of work, not working, retired, report more health problems than caregivers who work for patients who are employed. Next slide. And how does it impact the care that patients might receive? So we know that clinical trials are a really important part of developing new therapies and innovating, ways to treat patients. And yet there's only a very small number of patients that actually make it into clinical trials. And a lot of times clinical trials actually close early because they can't get enough patients to participate in them. And some of these obstacles are, how complicated they can be and how many expenses are involved just to participate. This is something that Ken touched upon, the hotels you have to stay in, the hotels your caregiver has to stay in, taking time off of work for you and your caregiver, the transportation back and forth. And we know that patients that have limited resources are underrepresented in these cancer trials. And so older patients, those that are uninsured, patients that come from minority populations or lower socioeconomic status are underrepresented in these trials. And this increases the disparities that we have in clinical trial participation. Next slide. So what do we do about it? I mean, there's a lot of levels that this problem can be tackled. And there are levels from the health system, from insurance, from patients and their families, from caregivers and providers. And so it could be really daunting when you think about, like Ken said, what do you even do about this? Next slide. I think this symposium is all about you, as survivors. And so I think the most powerful thing you can do is be your own advocate. And, a lot of times patients actually want to talk about costs, but they feel uncomfortable and are concerned that it might impact the actual care treatment plan they might get. And even though patients want these discussions, they rarely happen. And so I would encourage you that if it doesn't come up from your provider or from your treatment team, if there is a concern, to actually bring it up, because most of the time, just having these cost discussions can actually lower your costs through a number of financial navigation systems or support systems without actually ever altering the treatment plan. And so I really would encourage you and your families and friends to be your own advocates and bring these issues to your treatment teams. And with that, I'd like to turn over back to Dr. Chen.
Great. I would just like to thank all our survivors and medical panelists for these excellent presentations. And we want to now open up to you, our audience, for any questions. So I think I wanted to start off by really asking everyone on our panel to talk about sort of what are the most sort of costly aspects of head and neck cancer care in particular. So like for our survivors like Kenneth and Charmaine, what did you find to be some of the most costly aspects of your care?
Okay, my most of the surgery, the most expensive of the surgery. On top of that, there was other things that have expensive, such as radiation treatment and therapy. Also, I could pay for additional home care nurse for a couple of years helped me. I would say now, to pay more attention to details of insurance and to understand what the cover is, because I didn't have insurance. And okay, Kenneth?
Okay, for me, probably the biggest expenses have been that I had to stop working. So that was probably the big one. But travel, for instance, every time I go to Moffitt, it's 304 miles round trip. And I'm happy to do it. I'm retired, so, but it's an expense. It also takes a day. So for someone who is still working, that would be a real problem. But driving to Moffitt, if it was 1,000 miles each way, would be more than worth it for me. So but the biggest expense for me was having to stop work, and a lot sooner than what I had intended. So, but I've been blessed because I've had good insurance, but I've had deductibles and the many surgeries I've had out of town where my wife has had to come and stay in a hotel, and living expenses are a significant factor. But overall, I've been blessed, but my biggest problem was having to stop work.
Great, thank you. So for the audience, feel free to leave any questions for our panelist members in the chat. A question for Dr. Mady and Dr. Patel. I think Senator Kenneth brought up the point that he traveled quite far, to go to Moffitt to see Dr. Patel. For our audience, how do they sort of balance sort of the interest in going to a major tertiary referral center when they're so scared of sort of the cost of all that travel and the financial burden of that?
Thanks, Dr. Chen. I think that's a great point, right? The indirect cost, which Ken and Charmaine are referring to, the loss of productivity in not being able to work, and also the costs associated with physically driving to a tertiary care center can be quite daunting. I think that having a discussion with the whether it's the social workers or financial navigators proactively, I think is important. It's a fine balance between the cost part and, of course, the care. And for head and neck cancers, in some ways, a multidisciplinary care is equally important. And so it's a balance, but asking the providers and the treatment centers in what other resources are available is important. As Dr. Mady mentioned at the end of her slide, the best thing that patients can do is be their own advocates.
And we have a specific question for Dr. Mady. Bill asked, did your study include lost wages for caregivers and patients?
So thanks for that question. It's really important. The initial studies that we did where we just looked back at patients who had already finished treatment, we didn't ask those specific questions because we were, taking a snapshot in time of somebody's experience. We are, though, looking at that right now. We followed patients from the time they were diagnosed to the end of treatment around 6 months after they finished treatment, and tried to understand what kind of impact their cancer had on their employment and changes to their employment. I think part of what's going to be challenging to tease out is some of these changes have also happened with COVID, right? And COVID has changed how people have potentially gone to work, returned to work. And so I think there's going to be a lot of nuances in trying to understand some of those subtleties in terms of, cancer and COVID, which is a whole other sort of topic in and of itself. But I think trying to assess lost wages and sort of the hidden costs of treatment, like opportunity costs, what you give up in return for something else, the time you give up working, the time you spend traveling, the time your caregiver has to also give up at work and traveling, are all things that are harder to capture, but really important to capture as we try to understand this problem.
Great. We have another question for the audience. Eric is asking if perhaps Dr. Patel and Dr. Mady can comment on the potential impact of the new healthcare legislation on costs and reimbursement for survivors.
I don't know if Dr. Patel has more specific insight, but what I do understand about healthcare legislation is that it's very complicated, and our health system is so complicated that a lot of changes will really depend on your specific plan. And I think that it's hard to make generalizations about what one specific legislation or bill or change will actually do because of the level of complexity in the United States. So we have one of the most complex healthcare systems in the world. And there are so many nuances to coverage based on the type of insurance that, for example, even Medicare can be run like a very privatized insurance company. And so, I think it's hard to say yet. Time will tell as part of that, but a lot of it will also depend on your specific insurance plan. And so trying to understand your plan, like Charmaine was saying, what's going to get covered under your plan, what's not going to get covered, is something to try to understand, and is not easy to understand on your own. And that's why trying to bring up the conversation with your healthcare providers, and most of the time, let me tell you, your healthcare provider is not going to know either, and that's okay. And the whole goal is to get you to somebody who does know, because there are people who spend all their day looking at insurance plans, right, and trying to understand what's covered and not covered. And so maybe us in the office, we can't tell you exactly what's in network or out of network or what's covered, but we can help get you to the right person to start understanding your benefits and to start understanding what might be covered or not covered. And then going back to a point that Ken made in terms of travel, So we know that potentially the quality of your healthcare and your outcomes, can change depending on whether you're at these high volume centers, that do this all the time, right? However, starting to think of creative ways to work with providers back home in terms of your surveillance or potentially imaging is where we have to get creative, because asking, Ken to maybe come back every 3 months for a whole round trip day might not really be feasible. And if Ken has to bring somebody else with him, to also miss a day of work, and if you're doing that for 5 years straight, or if then you have another cancer and you're also trying to do that for another cancer, this is where all these little things start to add up. And so, what COVID pushed us to realize is that, there are ways that we can do care, right, virtually. And it's not for everybody and it's not perfect, but maybe this is just one aspect that we can start to integrate into the care plan to try to lower some of these barriers in terms of follow-up and the burden that's placed on patients in their care. But I do think it is critical to keep in mind that, sometimes it's a lot more upfront investment to travel and to get your care and do all that at these centers, because it does make a difference. It makes a difference on how patients end up doing, and then sort of working with your provider for the the aftercare part.
Yeah, I'll just reiterate what Dr. Mady mentioned. I think in terms of knowing the plan, knowing your insurance plan, I think is important. As we've looked at our patient population, approximately 50% of patients, both objectively and subjectively, don't quite understand what is in their plan. And frankly, majority of the healthcare providers probably also don't understand what's in their own plans if push came to shove and they were asked. So I think trying to educate that is important. And a lot of cancer centers do have some sort of resources, financial navigators or social workers who or a specific financial counseling office that can provide some of this information, and in fact, in some ways, be an advocate for the patient. So those are the important things to ask the provider. The last bit about sort of this providing the same quality of care from a distance is important, and as sort of lessons from pandemic have evolved, I think virtual care, telemedicine, really has come to forefront. For an example, I've just led a study, not specifically in head and neck, but across all cancer types at our NCI designated cancer center, which is the only one in the state. And it's a big state to travel. And on average, our patients are saying about $150 per trip, if we can convert that to a telemedicine trip, a telemedicine visit compared to an in-person visit. Now, again, not every patient is going to be eligible for it, but having that discussion, am I eligible for it, is an important part. Maybe for the first year and a half, 2 years, you're not. But as time evolves and the farther out you go in the surveillance phase or the survivorship phase, those are important things. We've started to offer dietitians appointments virtually, speech language pathology virtually. And so all of these things are important.
Great. So this is actually a great question from Hank, looking at asking about studies that look at the cost of care for the side effects of treatment, particularly like hearing loss, tinnitus, osteonecrosis, because as we all know, for some reason, dental care is not covered by most major insurance plans.
And that's a big problem.
Yeah.
That's a very, very big problem. I'm not aware of any studies that are looking at the side effects, the long-term side effects, and what is that costs associated with. I don't know if Dr. Mady has any thoughts on that, but I'm certainly not aware of it. It's a big component. I think we should definitely be looking at it.
I think some of this is that it's really hard to study, and that's part of the challenge in showing that it's a problem. You know, a lot of the dental care is done outside of the university setting, or with community partners that you may not be able to capture sort of these costs, right? And so we all anecdotally, mean like from our personal experiences, we all know this is a problem, but trying to demonstrate that it's a problem is a challenging one. It's something that I know that I've thought about a lot on how to try to figure it out. I know that everybody on this panel has thought about that, but it is a challenge. And a part of it is you have a lot of other stakeholders involved and competing interests, and it's sometimes challenging to bring these issues to light. But I think it's definitely on the radar of every head and neck cancer team. But in terms of showing that not having dental coverage impacts, things like financial burden is things that we're trying to figure out.
Great. And Edward has a question asking our panelists, do you feel like the NIH is properly prioritizing the funds dedicated to head and neck cancer? And he sort of quotes example of a paper he wrote where they demonstrated that dysphagia had a sort of $3 billion a year cost to the healthcare system. And, if we could better prioritize research funding into these areas, perhaps we could improve our chances of lowering the cost of the overall system in general. What do you guys think?
I think it's a very difficult topic to address in a short time, and there are a lot of competing interests. I will add, and this continues from the last question, and the answer is that I would say a decade or 15 years ago, the first, and even now, the first goal is survival, right? And it's only in the last little while that now we've done better and better and better with our therapies, not only the surgeries, but also getting more information on the patients that are appropriate for getting additional radiation or chemotherapy, and extending that survival. And now the prognosis, meaning the percentage of patients who do survive, is improving. And so some of these long-term side effects, which we didn't know 15, 20 years ago, are now coming to the fore. And these are presenting challenges that now we need to investigate forward.
Yeah.
Sorry, not a very specific question to the person who asked, but I think these are at least in my mind, some of the challenges.
So I will say that in general, financial burden is definitely high on the radar. There are now special requests from the NIH specifically looking for grants that look at financial toxicity and financial burden. When we look at head and neck cancer specifically, if you consider head and neck cancer in the lineup of, sort of most common cancers in the United States, head and neck cancer is not necessarily, one of the most common cancers. It's a much smaller disease group. So again, that goes into sort of the competing interests when the government and the NIH have to prioritize where do we give money. Part of that is how many people does this affect? And so that's not to minimize the consequences, but it's part of the struggle on trying to get this on the radar in terms of additional funding and legislation, even more so, because these questions about dental coverage and is it a medical necessity versus elective, all of that comes down to changing health policy and legislation. And that's a tougher thing to do when you're dealing with a smaller disease group.
And advocacy from patients like yourself, AHNS, Head and Neck Cancer Alliance survivorship, I think is critical in highlighting some of these aspects.
Great. We have a little less than 10 minutes to go. So anyone, if you have any last questions, put them in the chat. And I think I would really want to ask sort of each of our panelists to sort of talk about, ways in which, I know we've started touched on it briefly in our discussion, but what advice would they have really for our audience in terms of approaching their health care and trying to reduce the costs of care with respect to their head and neck cancer? So maybe our survivors can kick it off. Kenneth and Charmaine, any advice for our audience?
Charmaine, do you want to go?
You can go. I'll go after you.
Do you want me to go?
Yeah,
Go ahead, Ken.
Okay. Ladies first. Since I've had a long history, and I know a lot of fantastic doctors, and I've been very fortunate. Knowing what I know now, had I thinking about it, instead of going through a dozen surgeries, I might have been a lot smarter after the first couple of surgeries to get to a place like Moffitt, to get to a facility that deals with this every day and has doctors who deal with it every day, do research into it. And maybe I could have presented a lot of aggravation and a lot of expense along the way. So that's my mistake, but I had told that to a lot of people. We just had a friend diagnosed with cancer of the soft and the hard palate. And the first thing I told her was, you have to get to the right place. And she did. And she went to a place like Moffitt and like Emory and like, there's many great facilities, but she got to the right place, she got the right doctor, and she got a great prognosis. So that's all fantastic. But you have to end up at the right place with the right doctors, and you might save yourself a ton of expense, a ton of aggravation, and a ton of pain as well. And I said one more thing. You talked about with COVID being able to spread out where care is provided. After I had the surgery with Dr. Patel, I had radiation and chemo. They wanted to do it at Moffitt. Well, that meant I'd have to stay at Moffitt for 6 weeks, basically. But I had met with Dr. Harrison, who's the head of radiation at Moffitt, and I had a nurse advocate who I had explained my situation. My wife had put off serious heart surgery while I was going through all my stuff. And Dr. Harrison said, no problem. He said, I have an old friend and colleague in Fort Myers. He set me up with him. He set me up with a chemo doc, and I had it done 15 minutes away from my house. So, they go every day for radiation for 30 days and once a week for chemo for six weeks. But it worked out for me fantastic. And I still was followed up at Moffitt with the same doctors. And, so that saved a lot of time, a lot of expense. And I was able to be here while my wife had some serious heart issues fixed. So I'm very blessed. So, and what all of you people do is amazing. And, I thank you from the bottom of my heart for the efforts that you put in and how you help people. So thank you so much. And Charmaine, God bless you. I hope you stay healthy.
Yeah. Thank God I was blessed from Moffitt Cancer Center. The care that they made me feel safe and protected there. And good doctor, Dr. Patel, God bless you.
Amen.
He had a wonderful.
Oh, you guys are kind.
No, not at all.
Dr. Mady and Dr. Chen are very, very good.
Yeah.
I'm sure they are.
Yeah.
I've had the privilege to work with and know both of them. They're very good.
Yeah.
And I work with the team.
Yeah. All the surgeons there, the local doctor, but they're very caring. Yeah. And they're very clear about the patient. They have passion. And that made me safe and comfortable.
Yeah, that's really important. I think both of you guys have really touched on the fact that having a good team is really important. And also, Kenneth really advocated for himself and was able to find a good solution from his team of both his surgery team as well as his radiation oncologist to be able to sort of strike the balance between getting good multidisciplinary tertiary care as well as minimizing cost burden to him and his wife as well. So we have one last question. We've talked about sort of being patient advocates for yourself and bringing things up to your provider team. What if, you're at a center where there really isn't a nurse navigator, or when you ask the question, can I help you? They're like, I don't know. I don't have a social worker. What can you do then?
I would do some research, for myself and see what's out there can help, because there's some resource there, can help, but you have to do some research and find out how can we get the help and stuff like that. I was blessed with the strength after surgery. I could able to drive myself to Moffitt, thank God, and stuff like that. So that the driving mechanic really expensive for me because I still have to put gas, So that was good. So I would advise anybody to do some research, And because there's some source out there. It's hard that this source, also with Moffitt, are source that they can help you, because I went through the program, So that's what I have to say.
The most important thing you can do is be an advocate for yourself. And some people are afraid to ask a doctor a question. The doctors know. Ask them questions, and a lot of times they can help. So just be your own advocate.
Yeah.
I think those are great things. Go ahead.
I was just going to add, I think, I'm fortunate to be around a group of people that at a place where we can provide some of these resources. I think we do have community organizations like Zimmerman's Angels who don't specifically deal with head and neck cancer, but cancer patients in general. And they can also provide some of these answers that if there's no specific patient navigator or social worker that can help with it. Not sure if either of you have any other suggestions, but I think community resources is a big resource.
Yeah, I think there's the Patient Advocate Foundation as well, and a couple other resources. I think, you guys, Charmaine and Ken also made a great point, talk to other people, other cancer survivors, members of the Head and Neck Cancer Alliance, et cetera, do your research and make sure to keep asking questions to your provider and to your care team, because even if they don't know the answers, they can work to figure out a sort of compromise with you. So I really want to thank our survivors and their caregivers for attending our session. And a really special thanks to our panelists, Charmaine White, Kenneth Hansen, and Drs. Patel and Mady, as well as the Head and Neck Cancer Alliance and the American Head and Neck Society for their time in organizing and hosting this webinar. I hope everyone learned something, and I really enjoyed our time together.